Hi, it's Robert Cerfolio from New York City. Hope everybody is doing well. This next patient, we haven't started the video yet, is a gentleman, 71 years old, has a huge 9-centimeter tumor, received preoperative carboplatin, paclitaxel, and Keytruda. We're going to show you how to get control. Look at this gigantic tumor plastered to the chest wall. There's no invasion of the chest wall on CT or MRI. The ribs are not invaded, but you got to find the aorta. When you're coming down like this, you got to find the aorta, which we do. And you still have to remove all the lymph nodes. He had we had multi-station N2 disease. Now we're doing all these people with stage 4 disease because they're alive for so long. In any event, here we are now at the 27 mark, digging out the subcarinal lymph node. Now at the 32nd mark, we're getting around the inferior pulmonary vein. And now we're going to do a little fissure diving, see if we can do this. Now that is the A8. There is no 7 on the left side. So you can see the pulmonary artery is right there, the A8 pulmonary artery, but it's absolutely plastered. So I said, let's go to the top. Let's find the main PA. We're going to need to get control. Let's watch the recurrent laryngeal nerve. Let's take out our 5s and 6s. Here we're identifying the main pulmonary artery. Now we're taking it right off of the lower lobe bronchus at the 1 minute mark. And there's the pulmonary artery in the back. Remember, in the back, you can always try to find it. So we can get around some of this. Look at these giant bronchial arteries. We can try to identify some of the fissure, but it's just not safe. So we're going to open up the pericardium. We get in the pericardium, and there's an effusion. You got to send that for cytology. That came back negative, but you don't know at the time. Then you got to get around the main pulmonary artery. So first we're going to get the superior pulmonary vein pulled out of our way. We're not doing a pneumonectomy, we're doing a lobe. There's the main PA. We get around it very carefully, identifying the front of it, the back of it, an exit for the clamp, and get around it. We double loop it. Now we're putting clamps around it. There we're putting clamp around the main pulmonary artery, and now we're taking the inferior pulmonary vein at the 1 minute 45 second mark. Now we're going to try to do the lobe. So now we're going to do it like a VATS lobe from the bottom up. We took the vein first. We have clamps around the upper lobe vein. That's our distal PA. And now we're just going to divide the bronchus. So here we are at the 2 minute mark, dividing the basilar bronchus to the lower lobe, getting these huge lymph nodes all off the PA once you divide the bronchus. Now we haven't taken the B6. You have to be sure that this is just the basilar bronchus. This is the B8, 9, and 10. That's completed. If you're not sure, put a bronchoscope in. This is what we did here. Everything was so messed up. The bronchoscope proves the upper lobe's above us, which you can see here, and that's obviously the B6 going to the superior segment. So we're going to divide that now with a bipolar. This is the safest way to get control of the PA, is divide the bronchus. We say it at every national, international meeting, and still I get questions and emails about it. Here it is. Look at it on our video. Once you do this, the PA now becomes free, as you can see. And you can just staple this. So we're going to use a handheld black stapler. We take that. Now the lower lobe bronchus is taken, the lower lobe vein's taken. The only thing left is the pulmonary artery. So I try to get it from the front, and I still can't get it, believe it or not. I still can't safely get it. So I'm going to complete the fissure posteriorly. This is hard to do, but create your space. You dissect and dissect. So you can now see the back stay above the bronchus. Now we're taking the posterior fissure. Now we're around the PA. Now you can take the pulmonary artery safely. I didn't need proximal and distal control, so now I'm going to cut those off. At the end of the case, we give ICG. That proves that we have excellent flow in and out to the remaining left upper lobe. Thank you, Robert Cerfolio from NYU. This is how you get central PA control. And remember, the distal PA is the vein. So since this was a left lower lobectomy, you take the left lower lobe vein with a stapler, and your distal PA control here is the left upper lobe vein, which is what we got around twice. Thank you. Hope this helps all of you.